So we are taking questions here, of course. We're also going to be taking some questions from our participants online. And so our person in the back will notify me. And we've got a question right up front here, though.
Hi. I've got two questions, actually. The first is, living in England, did you see any difference in baseline pain between U.S. and America? The reason I wonder is I lived there, and I was shocked by how much they flogged the Tylenol. I wondered what that reflected.
Oh, they love Tylenol. The differences between people with pain in the UK and the US are almost indistinguishable in my experience. The things they go through are the same. The adequacy of socialized care versus our privatized care is maybe not as profound as we thought. The interdisciplinary pain rehab programs were not decimated there as they have been here, and maybe that's one area where they have a distinct advantage over us. Mm-hmm. And they also have socialized medicine, right? Which is maybe perhaps a distinct advantage, access to healthcare.
And the second question is, you mentioned that their tolerance was brought up on the cold test by having them link it to the plight of a loved one. I'm wondering if making this concrete yet retrospective could be valuable for populations like I work with, like refugees with really intractable chronic pain.
Sure.
If you say, okay, in 1975, you carried someone through the jungle for 4 days eating rats, and that's why you're here, and that's why you now have grandchildren. Sure. I'm wondering if anybody's tried linking it like that, and if it's shown any effect.
It's a good question. Now, at a statistical or a research level, I'm not sure that people have, but if someone said something like that to me clinically, there's certainly some important questions there to ask, like, what was that all about? And does that stuff that was all about still matter right now in your life here as a refugee and after all the things that have gone on? And in other words, likely a conversation around that would point the direction of some values, right, that maybe that can be made use of in the here and now, therapeutically moving forward. Is that all right? Okay.
Good,
Thanks for the question.
We have a question.
I have an online question, online question from Tom from Minnesota. He wonders what the treatment included. I guess a little descriptor of what did that look like.
In 2 minutes, right? Okay. So treatment, we've done ACT in a few ways, psychology only and also interdisciplinary. My preference is interdisciplinary. I just think it works better. So it included the interdisciplinary services of a lot of people. Treatment essentially was about looking at consequences of behavior, making sure that patients' behavior was getting them the consequences they want in the longer term. That's a values-related question. Talked about, we practiced areas of where room may be made for pain. So in other words, where decision-making can happen that's somewhat independent of pain. It's a hard question to answer because there's a good big literature out there. And if Tom from Minnesota sends me an email, I'm happy to send him some of that literature. In essence, what I won't be able to explain is everything that treatment entailed, but I hope what I've done today is given you a reasonable understanding of what the purposes of treatment were, what treatment was trying to achieve, and then we can work backwards from what treatment was trying to achieve to what treatment included to try and achieve that. If that's all right, I might duck that one a little bit. Thanks.
Another question over here to the right.
Yes.
Good morning.
Morning.
If I have a compliment but also a potential technical criticism, which would you like first?
It doesn't matter. I'm flexible, man.
Okay. The technical criticism, maybe, it's a potential one. When you showed the effect sizes, I'm curious, were those within group effect sizes or between group effect sizes?
That is absolutely right. I meant to say that. So these are all uncontrolled trials.
Okay.
So these are within subject effect sizes controlled for within subject correlation. So we try and attenuate the correlation a little bit based on baseline values.
Okay, so I would be, as someone who works with effect sizes a lot, I would be using Cohen's sort of standard for those effect sizes. I think that really applies much more accurately to between group effect sizes. Otherwise, you get what looks like an inflation.
So what we did, and I can show you here, is we tried to, what's the formula? I say it down here. We controlled estimates for within participant correlation, and that seemed to be the best thing to do to try and get effect sizes, but I take your point as very accurate. I mean,
yeah,
this is
and I mean, regardless, I think you've got, those are impressive effect sizes. I just would, I'd be a little cautious sort of thinking about them according to the same, for the compliment. So that was the technical criticism. The compliment, I'm really glad that I got here in time for your talk. I think it was very impressive to kind of connect a little bit to what Raven Sara said, and I suspect you probably know what I'm going to say, but I want to say it anyway. There's a lot of interesting connections to what you're doing, and what existential psychotherapists would have been thinking about when they were developing their ideas.
Yes.
The reduction of struggle rather than emphasizing struggle is consistent with paradoxical intention.
Yep.
Connecting pain to something meaningful is classic logotherapy type
Absolutely.
of stuff, and which, unfortunately, existentialism in psychology is kind of a scientific dead end. It's hard to operationalize the things, and yet clinically it's really interesting and really valuable. Thanks.
Yeah, sure. Thank you. The way that I came to ACT was through behavior analysis, and the way that I was originally exposed to it was within the confines of an integrative psychotherapy course, where we started with existential therapies. There's a lot of Gestalt in here. There is a little bit of psychoanalysis in here, at least to the extent that in ACT, we value shutting up as a therapist and listening, and I think the psychoanalysts were able to do that in spades. There's a lot of behavior analysis in here that we're trying to be sensitive to reinforcers and punishers and appetitive and aversive control and getting behavior change. And there's some CBT in here too, which is that perhaps thoughts are important but not quite as causal from an ACT perspective as CBT might say they are. So my understanding of ACT is that it is reasonably integrative of all these approaches and tries to be very clear in its outcomes, in the outcomes it's attempting to achieve. Thank you very much.
Hi. So I'm curious in any of your assessments
Thank you.
Of the outcome,
Yeah.
if there's differences that you've seen between males and females?
We have.
Or-
There was a question like this yesterday, maybe for Allison's talk. We've tried to look at treatment predictors, and we have always failed to find a salient predictor of treatment outcome. We've looked at gender, we've looked at baseline values. In general, people who are more distressed get less distressed. Is that regression to the mean or a bigger effect? But things like diagnosis and gender and age and pain duration, they don't seem to be reliable predictors of outcome, not that we can detect.
Okay, we have time for just one more way back to the right.
Hey.
Yeah, I have a question just about ACT, kind of under the bigger umbrella of CBT. You mentioned at the end almost like a comparison with CBT. My understanding is that it's, at least some consider it to be almost a evolution of other CBT type interventions. And then just if you have any take on the interplay between it and other CBT type interventions like graded exposure and activity and some of these types of things, and how, I assume it's not one or the other, that there's interplay and be done simultaneously.
I think psychology, we like to fight about theory, right? And we'll fight to the death against our fellow psychologists for that. I think we've avoided that, the CBT versus ACT wars, if you will. I think we've avoided that in pain for a few reasons. One is I think the message of ACT, which is let's get people back to living, it fits hand in glove with the reality of what pain is for a lot of folks. The two areas where I think ACT might differ from CBT are around the causality of thoughts. I think from an ACT perspective, we would say thoughts are influential, but they're not causal to behavior in the same way that cognitive therapy or people like Beck or Ellis would say they were. And I won't talk a whole lot about that, but there's a hypothesis about cognitive causality that seems to be in cognitive therapy. So ACT does not have that same causality chain. It would say that behavior is causal. The causes of behavior are multifaceted, and what we do in treatment is we try and identify the ones we think are salient, and that can include history and situation and thoughts, but it can also include a lot of other stuff. And the second difference, I think, in ACT as it compares to CBT is the centrality of values-based action as this is our outcome that we're shooting for, adequate quality of life. And I know that's in a lot of approaches, so that's not the sole ownership of ACT. And I think CBT has that in it. Goal-directed behavior is certainly a part of CBT. Some values-based action is certainly a part of it. In ACT, maybe it's a difference in focus and emphasis that, as I understand ACT, it is the focus and emphasis. You had another part. There's another part to your question that I'm not remembering at the moment.
Just the interplay between it and other types of CBT approaches.
Right. So I would say ACT is absolutely an exposure-based exercise, an exposure-based treatment. That's what we're trying to do. It's both exteroceptive, in other words, putting people in situations that maybe have been previously avoided, like going to the gym, but it's also interoceptive, which we know is important in exposure-based therapies too, of exposing them to internal experiences that they're trying to avoid as hard as they can. Maybe I'll stop there because I could ramble on, and I know that I got the hook coming.
Well, thank you very much.
Sure. Thank you. Thanks for having me.